Assalamu alaikum students. Today we'll be talking about dengue fever. So we will be talking about dengue fever, what is the magnitude of the problem, the factors that are responsible for the transmission, pathogenesis of the dengue infection, its case classification, clinical spectrum, management of the infection, and various preventive and control measures. So dengue fever is an acute, infectious, arboviral, self-limiting disease which is caused by one of the four closely related dengue viruses. It is transmitted from person to person by the bite of an infective female Aedes mosquito. It is clinically characterized by fever, headache, severe muscular and joint pains. The disease is usually non-fatal, but sometimes it can cause severe hemorrhage and profound shock which can prove to be fatal. After malaria, it is the most common cause of fever in India. Coming to the magnitude of the problem, it is a major public health concern throughout the tropical and the subtropical regions of the world. It is endemic in more than 100 countries in this region and gives rise to epidemics and even pandemics. In 1998 pandemic, WHO reported 1.2 million cases and 15,000 deaths. The Americas, Southeast Asia and the Western Pacific regions are the most seriously affected. So we see in the figure the areas where this dengue infection is very much prevalent. Now the estimated prevalence of dengue is 3.9 billion people in 129 countries and 70% of the actual burden is in Asia. Dengue fever was enlisted by the WHO as one of the 10 threats to global health in 2019. The number of cases reported increased from 2.2 million in 2010 to 4.2 million in 2019. In India, the first epidemic occurred in Vellore district of Tamil Nadu in 1956. 10 years ago, it was limited only to urban areas, but now it has percolated to rural areas as well because of the suburbanization and the water storage practices. Thus, we can say that dengue fever is an emerging public health problem in India with cyclical epidemics. Now, coming to the agent factors, dengue virus belongs to the group Flavivirus and family Togaviridae. It is an RNA virus which is spherical in shape and measures 17 to 25 micrometers in diameter. It has four serotypes, which includes DENV1, DENV2, DENV3, and DENV4. Now, there is no cross immunity, which means that infection by one serotype does not confer protection against infection by the another serotype. Now, the virus is destroyed by heat and chemicals. Now, coming to the communicability, the virus can survive at -70 degrees centigrade for several years. All the four serotypes have been isolated in India. The period of communicability is first 4 to 5 days of illness. Reservoir of infection is the case of dengue fever, and the carrier state does not exist. For every clinical case, we have 4 to 5 subclinical infections. Coming to host factors, it can infect any age group and is common among infants and young children. Incidence is more among men as compared to the females because the exposure is more. One attack confers specific immunity for 9 months, and several attacks with the same serotype confers lifelong immunity. The transmission is by the bite of an infective female Aedes mosquito. Now, coming to the environmental factors, the risk of dengue has increased due to the rapid urbanization, industrialization, lifestyle changes like using coolers, eruption of slums, and improper water storage practices. Coming to the vector, the most efficient vector is Aedes aegypti mosquito. The mosquito is black in color with white strips on body and legs, and because of this, it is also called as tiger mosquito. It is an aggressive day biter, and the highest biting intensity is at dawn and dusk. It is enterophilic, that is, feeds on human blood, and biting is done by the female mosquitoes. The picture shows the various collection of water which are the breeding places for the mosquito. Now coming to the breeding habits. Mosquito breeds near human habitations in clean water which is collected in artificial containers like we have coconut shells, tires, air coolers, etc. The mosquito life cycle from egg to larva, pupa and then adult takes 8 days and occurs in water. After a blood meal, the virus multiplies in the body of the mosquito and reaches the salivary glands when the mosquito is said to be infective. The extrinsic incubation period is 5 to 7 days. Now, this is the cycle of transmission. Once the mosquito becomes infective, it remains so throughout its lifespan of about 2 weeks. The virus undergoes propagative type of biological transmission. Transovarian transmission is also seen, and it takes place from infected female Aedes mosquito to the next generation through the eggs. The less efficient vectors include Aedes albopictus, Aedes polynesensis, and Aedes scutellaris. Adult mosquitoes usually rest indoors in dark areas and have a limited flight range of not more than 400 meters and do not ascend the height of 15 feet. Coming to pathogenesis, once a mosquito bites and the virus enters the body, it can cause either direct cell injury or indirect cell injury. In indirect cell injury, it causes endothelial cell damage, macrophage activation, and platelet destruction, which can lead to severe dengue characterized by shock, massive bleeding, and multi-organ failure. In case of the indirect injury, this production of antibodies and T cell activation, which together cause vasculopathy, coagulopathy, cytopathy, and organopathy. And these factors ultimately lead to severe dengue, again characterized by shock, massive bleeding, and multi-organ failure. Coming to the dengue case classification, dengue infection can be either symptomatic or asymptomatic. In case of the symptomatic patients, it can be mild, moderate, or severe. Now, in case of mild dengue infection, we have fever of 2 to 7 days with any one of the following, which includes nausea, vomiting, rash, headache, retroorbital pain, myalgias, arthalgias, and leukopenia. Now, the moderate infection, it can be with high-risk comorbid conditions or with warning signs and symptoms. Comorbid conditions includes infancy, old age, pregnancy, patient on immunosuppressants, on anticoagulant drugs, patients with chronic infections like TB, HIV, with chronic illnesses like diabetes mellitus, hypertension, chronic kidney disease, or any coagulation disorder. And the warning signs and symptoms include recurrent vomiting, abdominal pain and tenderness, lethargy or restlessness, pleural effusion ascites, minor bleeding from any site, cold clammy extremities, rapid pulse, narrow pulse pressure, hypotension, hepatomegaly, progressive increase in hematocrit, and rapid fall in the platelet counts. And severe disease is characterized by shock, severe or multiple organ involvement, and severe bleeding, which includes hematomesis, massive menorrhagia, or melena. Coming to the various clinical manifestations of the dengue infection, we can have asymptomatic dengue viral infection, or there can be an undifferentiated viral fever syndrome. There's classical dengue fever, dengue hemorrhagic fever without shock, and dengue shock syndrome. In asymptomatic dengue viral infection, we have no symptoms and the infection is subclinical. In undifferentiated viral fever syndrome, the symptoms are mild, which includes fever, headache, body ache, loss of appetite, and maculopapular rash. In classical dengue fever, we have sudden onset of high fever of 2 to 7 days duration and is characterized by severe headache, severe body aches, joint pains, retrobulbar pain, maculopapular rash which does not blanch on pressure, hemorrhagic manifestations like bleeding from nose, gums, or easy bruisability. And we have a positive tourniquet test which indicates increased capillary fragility. And the test is said to be positive if we have more than 20 petechiae per 2.5 square centimeters of skin. In dengue hemorrhagic fever without shock, a person has all the features of dengue fever, plus hemorrhagic tendency, which is evidenced by definite positive tourniquet test, petechiae, ecchymosis of purpura, spontaneous bleeding injection sites, hematuria, hypermenorrhea, and melena. We have a platelet count of less than 1 lakh per cubic millimeter and a rise in hematocrit of more than 20%. We can have pleural effusion, ascites, or hypoproteinemia as well. Now is the dengue shock syndrome. In this patient has all the features of dengue fever, a positive tourniquet test, hemorrhagic manifestations, and evidence of plasma leakage. We also have profound features of profound shock, which includes acute abdominal pain, rapid and thready pulse, narrow pulse pressure, hypotension, profuse sweating, undetectable blood pressure and pulse, and cold, clammy skin and restlessness. And the case fatality rate is almost 50%. Coming to the lab investigations of the dengue fever, firstly we have a platelet count of less than 1 lakh and rise in the hematocrit of 20% or more. Then we can detect dengue antigen non-structural protein in serum by ELISA within 5 to 7 days of the onset of symptoms. Then is the detection of the antibodies in blood. IgM can be detected after 4 days of the illness and IgG at the end of 7 days. RT-PCR detects viral genome in the serum and is definite proof of current infection. IgG ELISA helps in differentiating between the primary and secondary infection. If the rise of IgG titer is more than 4-fold during the convalescent phase, it means the infection is secondary and there is more chance of complications. Then is the PRNT assay or the plaque reduction and neutralization test assay, and they are the most specific tool for determination of the antibodies. And then we have the emetoplatelet fraction. IPF of more than 10% means that the person is out of danger, and if it is less than 5%, platelet transfusion is required. And this is how we grade the severity of the dengue infection. In dengue fever, we have fever with 2 or more of the following, which includes headache, retroorbital pain, myalgias, and arthralgias. In dengue hemorrhagic fever grade 1, we have all the above features, plus a positive tourniquet test, which is an evidence of plasma leakage. In dengue hemorrhagic fever grade 2, again we have all the above signs and symptoms, plus an evidence of spontaneous bleeding in skin or other organs, which may include black tarry stools, epistaxis, bleeding from gums, etc. And we have abdominal pain as well. In dengue hemorrhagic fever grade 3, in addition to above signs and symptoms, we have evidence of circulatory failure, which includes weak and rapid pulse, pulse pressure of less than or equal to 20 mm mercury, or high diastolic pressure, hypotension with the presence of cold, clammy skin, and restlessness. In dengue hemorrhagic fever grade 4, we have profound shock with undetectable blood pressure or pulse and a hematocrit rise of more than 20%. The lab findings are almost same in all the grades. Now in dengue fever, we have leukopenia and thrombocytopenia, whereas in dengue hemorrhagic fever, we have thrombocytopenia and hematocrit rise of 20% or more. Now coming to the management of the patient with dengue fever, we have to ensure the rest and isolation of the patient. To control fever, we have to give paracetamol, but avoid brufen and salicylates as they can cause gastritis or bleeding. Then oral fluids and electrolytes are to be given for patients with moderate dehydration. If hematocrit is more than 20, IV therapy has to be initiated with crystalloids like normal saline. If there is no improvement, therapy has to be increased and oxygen started. Still no improvement, we have to start with a blood transfusion. In case of acidosis, sodium bicarbonate is to be used, and if the platelets fall to 5,000 to 10,000 per cubic millimeter, platelet-rich plasma transfusion is to be given. What is the formula of 20? Rise in pulse by more than 20 per minute, fall of BP by more than 20 millimeters mercury, difference between the systolic and the diastolic pressure of less than 20 millimeters mercury, and presence of more than 20 hemorrhagic spots on arm after tourniquet test. These features suggest a high-risk situation and the person requires immediate medical attention. Coming to prevention and control, firstly is the elimination of the reservoir, and it consists of making the infectious cases non-infectious. However, it has a limited role in the control of dengue fever. Secondly is blocking the channel of transmission. It includes anti-larval measures and anti-adult measures. Anti-larval measures include destruction of water holding containers around the house and covering the water storage containers. Among the anti-adult measures, we have use of organophosphorus compounds. Then is the protection of the susceptibles. General measures include using full-length clothes, mosquito repellents, mosquito curtains impregnated with synthetic pyrethroids, and screening of doors and windows. Specific measures against dengue infection is the use of vaccine. Now, firstly, the vaccine which we use is the dengue vaccine, CYD-TDV, also called as the Sanofi Pasteur. It is a live attenuated vaccine which is tetravalent and available as freeze-dried powder of one dose with 0.5 ml of solvent in a pre-filled syringe. 3 doses are given at 0, 6 and 12 months subcutaneously for those who are aged 9 years up to 45 years and is marketed as Dengvaxia. Then we have Denvax, a recombinant chimeric vaccine. We have Tetravax DV, which is a tetravalent admixture of monovalent vaccines. Then we have TDENPIV, which is an inactivated tetravalent vaccine. And lastly, we have V180, which is a recombinant subunit vaccine. And this is all about today's class. I hope you have got some idea about dengue infection. Thanks for your patient listening.